I'd like to welcome everyone to the monthly webinar series for WEDI members. Thank you for joining us today. Before we get started, I want to take a moment to go over just a few administrative details. As you have noticed upon joining the webinar, everyone has been placed on mute for the presentation. At the end of the presentation, there will be a Q&A session. So in your GoToMeeting control panel, you will see a questions box. Please type your questions or comments into the field and hit enter. Please note that this webinar is being recorded, and all attendees will receive the follow-up link to download the recorded webinar, watch the recorded webinar about an hour after the live webinar, and you can actually download the slide deck in PDF format from the handout section in your GoTo control panel. Without any further ado, I'd like to go ahead and hand it over to today's speaker. Steve, it's all yours.
All right, thanks a lot for having me. This is Steve Posnack from ONC. I'm the Executive Director of the Office of Technology here. And part of that caveat at the beginning was I only get one take at doing this, so I will do my best. I'll probably go through, 20, 25 minutes thereabouts. Predominantly wanted, as the request was made, for those of you that weren't able to make it to ONC's interoperability forum this summer or missed one of the days that were webcast, wanted to give you all kind of a full flavor and overview of what occurred, some of the main points that came out of the session as well, and how to continue to engage with ONC going forward in the future. So very much appreciate your time, taking some time out of your busy schedule to join me. I am going to dive right in. A few just brief notes about ONC. I'm sure many of you from WEDI already know who we are and what we do. I have a few of those just general slides that we've kind of refreshed and made more modern in the 21st century way that we've got going on. So we really focus on two things in a nutshell. One is bringing the administration's priority of building a health system that delivers value and maximizes the promise of health IT. We've been working on this since ONC was created, and we use a lot of our leverage both as a coordinator, as a regulator, as funding agency as well through cooperative agreements, grants, and other such avenues to accelerate individuals' ability to access and send their health information, as well as to be able to more participate in their care, both from a shopping for care perspective. And you've seen a lot of activity from our sister agencies, especially CMS, about that, and then their ability to better coordinate care for themselves, for their kids, for their loved ones, parents, etc. We have a mission statement. I'm just going to, go through that pretty quickly. It's there for you to read. It's on our website as well, part of our stock slides. So one of the things that's unique, especially for those of us that have been around long enough in the health IT space, is that, especially from a federal government perspective, one of the things that drives the executive branch is the legislative branch. And, for all of you that are students of health IT history, you may remember about, 8, almost 9 years ago now at this point, the HITECH Act was passed, and that focused on, expanding the interoperability infrastructure. ONC got over $2 billion to make those types of investments. And so we worked on funding state health information exchanges, the regional extension centers, workforce development related programs, some innovation initiatives. And we also, stood up a lot of the structures that still remain today. So from a regulatory perspective, our approach to adopt standards and certification criteria for health IT products. We also created the health IT certification program, and kind of many of the other kind of policy activities that we're involved in as well. So fast forward to 2016, we had the 21st Century Cures Act that got passed by Congress. And this really was the first substantial update to ONC's legislative or statutory authority since the HITECH Act was passed. And so again, for those of you that are health IT history students, ONC was formed in 2004 as a result of a Bush era executive order. We kind of remained that way into 2009 when the HITECH Act was passed as part of the Recovery Act. That was really our first authorizing statute and kind of legislative authority that we have. And then the Cures Act came forward again at the end of 2016, right at the end of the Obama administration, that layered on a whole new set of responsibilities for ONC. Predominantly, they kind of fit into these two buckets that we typically focus on. So one is around interoperability efforts to increase, nationwide accessibility, availability of, many different things. But what we look at specifically has to do with the promotion of application programming interfaces, or APIs, which we all experience in our day-to-day lives through many other consumer industries. We also have specific authority under the Cures Act to look at information blocking, and the relevant provision there is associated with Congress had set penalties now for information blocking. They defined information blocking, and so there's a particular statutory definition that you can go and consult in the law. And then they said, we know this is a broad definition. There may be instances where, withholding information might be appropriate, and we're going to let the executive branch figure that out. And so they asked us to, or charged us, so to speak, to issue regulatory clarifications that would, as we describe them, be the exceptions to that information blocking definition. And so we're working on those rules. We expect them to be out this fall, so you don't have to wait too much longer. But that will really be a new set of policy and a new policy landscape from a health IT perspective that everyone will need to kind of wrap their head around. We've certainly been doing it for the past 2 years, so I know it's going to take a little while for everyone else to kind of catch up. So that kind of time release aspect, when you talk about regulatory work that goes on. The other kind of components that we look at from an interoperability perspective are ways to accelerate data exchange among health information networks, as well as to promote patient access. We're going to talk about those two together because, as you well know, and I'm sure many of you are participants in either Commonwealth or Care Equality or eHealth Exchange or the SHEEC, as it goes by from its acronym. And, there are ways in which all of those are very successful at this point. We want to, create those bridges between those networks. And the way that Congress charged us again to do that is to create what's called a trusted exchange framework and common agreement. So we've been working on that. I'm sure many of you through your WEDI participation have provided comments in those earlier drafts, and we'll have an opportunity to do so again in the future. Last but not least, and if you're on this call, you probably dialed in to the Health IT Advisory Committee yesterday. They had their all-day meeting in person, at which I got to make some remarks as well. Again, another Health IT history moment. You may be familiar with the Health IT Policy Committee and the Health IT Standards Committee. Those are the two federal advisory committees that came out of the HITECH Act of 2009. And at the time that the 21st Century Cures Act was passed, Congress decided that it would be appropriate to sunset those two federal advisory committees and kind of combine the policy and technology efforts into one advisory committee, which is, you could say unoriginally named the Health IT Advisory Committee, but such is life, right? So that's really a kind of big overview of some of the intersections, things you can expect from us into the future as a backdrop for the interoperability forum that we held this summer. And the kind of second component is also in the 21st Century Cures Act is a provision around evaluating provider burden across many different dimensions. And so we've been working really diligently with our colleagues at the Centers for Medicare and Medicaid Services about ways to reduce provider burden. So I'm sure you've probably seen some of the proposals that have come out of our sister agency at CMS around, ways to change payment program participation, around ways to change documentation requirements as well. And, there's equally kind of a component that ONC is looking at in terms of, as new technology has been deployed, are there ways, best practices, other ways that we can engage industry to help make technology make people's lives better, as it has in many other industries. And, we're looking at ways to have the technology, be it new apps, ways in which they can plug in and use application programming interfaces and things of that nature that can improve provider burden. Across the clinical, staff perspective, it's not just doctors, it's nurses, it's everybody that's involved in using health IT. All right, and I almost forgot that I was running my own thoughts. So here we go. I'm going to dive into the deep part of the agenda here for the Interoperability Forum. And just go through some highlights of the tracks. So when just as a brief overview, this is the second one, so I often refer to it as the sequel. And we had our first one last year around the same time in August. Pretty much consistent on the goals that we had. We wanted to make sure that everyone in attendance or via the web was getting an update on kind of what's the national pulse related to interoperability and how are things advancing nationwide, as well as because we had breakout sessions on day 2, full day for the in-person cohort, really trying to identify what are some concrete actions that could come out of everyone meeting together. This is leveraging ONC's superpower as a coordinator and getting folks in a room and kind of really diving down and talking deeply about particular issues. So we focused on several themes: improving individuals' access, looking at public health priorities in a broad scale, and again, reducing provider burden, which, it can manifest itself in many different ways. And so we formed 7 kind of topical tracks. We invited some industry leaders that had expertise in those topical tracks, which I'll cover in just a second, and supplemented and kind of complemented that expertise with some ONC subject matter experts as well. And so we really had this public-private partnership between our ONC staff and industry leaders to really shape the interoperability forum as a whole. And then we did a recap of the whole day 2 experiences for the third day of the event. So just as a few brief changes, relative to the recap. Last year's forum, we only had one day. We kind of locked everybody in the same room. We did a big, set of plenary sessions, panels, and the like. This time, we had 3 days. We did the first part had, large webcasts, kind of demos, other sorts of keynotes, both from Dr. Rucker and Administrator Verma. And then we broke out into the deep dive track sessions. And then on day 3, we had kind of a recap synthesis day. So it was 3 times the fun from an interoperability perspective. And, as part of day 1, we also had some interesting discussion from the Blue Button 2.0 presentations that came out of CMS. And so I'm sure many of you are aware, especially given this crosses over into Wheaties, core territory, about, the access to claims data through the Blue Button interface that CMS put forward. We also had a video presentation. There's a link available to the National Partnership for Women and Families. We had a cooperative relationship with them about consumer access to health information and women's, role in providing, as the caregiver in chief, I believe they refer to the family members. So that was a neat video that was very brief that they showed, but it's also something available for you if you want to, share it with folks that you may interact with. Just in terms of quick metrics, so like I said, the sequel is definitely better than the original. We had over 400 people attend in person, several hundred more attend via the webcast on both of the days. I got contacted by people that were international, so it's really great to see the level of engagement that we had. And these are just some of the other data points related to really the combined efforts of both our private sector stakeholders as well as the people that we recruited from within government. So the tracks that we established, the 7 that we had, and I won't read these off for you because I'm going to cover each of them individually. There were these 7 here, and I'm just going to dive right in to the patient matching track. So when it comes to patient matching, as you all probably well know, there are a lot of challenges and opportunities. There have been a lot of advancements in terms of how the technology is shaping up. And that includes, new technologies or extra layers associated with what may be called referential matching, the use of biometrics as an additional identifier, and then, as the saying would go, artificial intelligence or, kind of machine learning techniques that we've seen as well. You may be familiar that ONC had put on a challenge contest about a year or so ago about patient matching algorithms. And we put out a synthetic data set and let, people bring kind of their best algorithm to it. The other things that were discussed as part of this track were that technology is, a part of the overall challenge that we face with respect to patient matching, but so too are some of the data quality issues. And that has that human element associated with patient matching. And so it's not to overlook. ONC has worked with industry as well. We have a patient data, demographic data quality framework and guidance that you can consult on healthit.gov that's been released about improving data quality. So this, makes it not so much garbage in, garbage out, but makes it more high quality data in that can then be used downstream for some of these other purposes for which we need when it comes to patient matching. Equally important, there are unique aspects depending on the types of populations that were involved. And one of the things that this track decided to take on from a discussion perspective was to look at pediatric populations that don't have the same cluster of commercial data that may be available to us as adults. So it's kind of an interesting, component, especially when we're looking at having longitudinal health records and things of that nature to really find ways to bind, people's identities, all the way down from effectively day zero of your life. So when it comes to interoperability measurement, and my team knows that this always gets me riled up and in an excited mood because there's so much we can do here, so much potential. And, every time you look at a new study via, any of the ones that, CLASS, AMA, AHA, many others, WEDI included, and, you look at the data and you're like, oh, this is great, but, we could, intersect it with this, or we could look at that, or we could, find that next measure downstream to get a better sense at a more detailed level about, what are we really making progress here? Where's the national impact? Where are the outcomes, and the changes there? What's the delta that's available? So I happened, if you could tell, I sat in the second half of this meeting in the afternoon, and so some of the outputs, upon reflection for this is we are getting more data, but it still feels, at least for the people that were in the room, that we're only really getting a small slice. There's a limited amount of data available from an interoperability measurement perspective. And, how we get the type of measure, the measurement information that we have today is often via surveys or self-reported. And I think there's an aspirational aspect of, how can we use the health IT that we have, again, without imposing new burdens per se on the users or the networks that are facilitating exchange to publicly report in a more transparent manner some of the data that could be, seen as the exhaust of the actual use of health IT. So I think there's an interesting and a component of a lot of the mind share going through now, looking at the best ways to leverage the technology and the infrastructure that we have to generate some new metrics that may be able to be used as proxies or as to complement kind of some of the existing survey methodologies that exist. So they did talk quite a bit about testing and applying novel approaches for measurement, looking at specific use cases, using audit log data and things of that nature, as well as, any ability to build some of the measurement capabilities into particular technical standards insofar as they're able to be, used from a measurement perspective. So this got us off on an interesting digression that I started, I would say, that I'm now torturing people with. So when we talk about interoperability measurement, and I raised this at the Health IT Advisory Committee yesterday, for those of us that sit here with a policy wonky hat on, we can look at some other industries in the way in which, kind of public policy centers its measures around. And so one is around internet access. And so, we have measures around the nation's and our citizens' access to broadband. And so we have kind of a rough sense of like, here's what the percentage of the population that has broadband access and it has a definition, et cetera. And healthcare is a little bit more complex than that in terms of, all the various use cases that are associated and the various different stakeholders that are involved and the ways in which the interactions occur. But are there certain types of things, and this is kind of a, eye in the sky type of thought here of are there certain types of measures that would give us that broad industry landscape kind of view? And, are there others, though, that, we need to start working our way downstream to figure out how to best identify the aspects of interoperability that are both the most valuable to measure and understand, and the ones that will help us, make changes to our policy efforts or technical deployments or the way in which, users are engaging with systems. So I could go on and on about this, at length for the slide, but I'm going to keep moving on. So from a security perspective, this was a track that went to one of the topics du jour, and that was distributed ledger technology, inclusive of blockchain. They also discussed the privacy and security considerations associated with APIs and how, as patients gain more control in their care coordination, vis-a-vis particular, patient-oriented services and the apps with which they interact. I'm sure many of you are familiar with Apple's entree into this space with their health records app, and then that kind of subsequent partnerships in terms of you being able to share data. So, really understanding, kind of the access control, the authorization aspects, the identity proofing and trust components. And so those are really the usual cluster of, I would say, for those of you that are security minded, components that, follow along in that kind of track. With respect to content interoperability, another world in which I live quite a bit, they really discussed, the two predominant standards that many are using today, deployed in the field. One is around the consolidated CDA, the CCDA. The other is around, FHIR itself. You equally may be familiar with something that ONC put out at the beginning of the year associated with the Trusted Exchange Framework, which is this concept of the U.S. Core Data for Interoperability. And so that's that USCDI acronym. The USCDI is our kind of first policy proposal out there for comment around how to expand and really meet the Cures Act's charge to look at all the data that would be necessary for interoperable exchange. We currently have in our rules, if you're familiar with them, a construct that's called the Common Clinical Data Set. And that as through the meaning use stages, if you're familiar with that program, included a certain set of data that needed to be exchanged, to meet certain meaningful use objectives and measures. And so that's evolved over time. And now we're looking at a place where we've kind of gotten an inflection point where we have an opportunity to work with industry to create a new opportunity to frame out a broader set of data, create a predictable roadmap and schedule, and also describe the how it's possible for different stakeholder groups to work their way up a maturity process and ultimately get data recognized to be part of the USCDI proper, I would say. So other aspects that were discussed as part of this track included the continued need for test tools and exploring future opportunities for validation of the standards. As many of you know, it's especially those of you that have lived in the claims world for quite a long time, it's important to get the standard, a standard out there for something. It's important to get data structured in an appropriate way, and it's important to get it, transported from one place to another. Equally important is having tools out there for the health IT developers and other systems integrators that can really make sure that the file is going to be valid and it's going to be accepted on the other end. So there's kind of a continued recognition that these are not to be overlooked from the overall ecosystem of how we deal with content interoperability and the standards that are available. The other aspect that they talked about a little bit in terms of successes and challenges is, as we all know, from a certification perspective, ONC's program focuses on the systems traditionally prior to their deployment in the field. And once systems get deployed in the field, there are configuration issues, there are customization issues, other sorts of variations that creep in as part of deploying software in a production environment. And just as a flavor of some of the duties and responsibilities that Congress added as part of the 21st Century Cures Act, there's a new what's called condition of certification that will require health IT developers to conduct real-world testing and be part of real-world testing for their certified health IT. And so that's another thing you can look forward to seeing when our proposed rule gets released later this fall, associated with addressing one of these issues that has come up over time in terms of where certification was engaging with the products and then where the ultimate kind of provider and user experience was once it got deployed in the field. All right. So I'm getting pretty close to the wrap up here for my summaries. Just a few more to go. The one that was, I would say, really interesting from a track perspective was the clinician experience with interoperability. And again, this kind of went across the spectrum of different clinical users. There's an aspect of the clinician experience that is certainly different between the ambulatory setting and the inpatient settings, as well as the transitions between. There's a lot of work going on, and one of the projects that was highlighted, which is a long-running project, about 5 or 6 years now, is something called 360X, which actually like 360 and 360X is probably an overused term in somewhat from an industry perspective. So the more specificity associated with this is around closed loop referrals, and so it's a mixture of using the DIRECT project protocol standards as well as HL7V2 messages to really orchestrate a communication between a sending and a referring and receiving provider, specialist in most cases, and how to close that loop between the two and share data between. The other component that was part of this discussion had to do with how to handle behavioral health, mental health data that's protected under 42 CFR Part 2, as well as the use of clinical decision support and some novel tools that are now starting to emerge, one of which is FHIR-based, is called CDS Hooks. It's a way for health IT to interact with CDS services and kind of get that clinical decision support put back into the user's workflow. All right, interoperability infrastructure. I also had an opportunity personally to attend this one in the morning part. And the big recap is we've got health IT, HIE networks that exist out there. We had a number of presentations from the leaders of those networks, talked a bit about the barriers and challenges associated with, taking networks to scale, how you communicate across, the different priorities that some of the stakeholders within those networks have, and has clearly kind of indicated the way in which they've deployed their technology and what they're trying to support, but also saw a lot of convergence in terms of everyone's on the same team. Everyone wants to exchange data for the benefit of the patient. And, I think we've seen in the past, even 2 years, a lot of progress be made, across the cross-network exchange. And, kind of important factors are, still looking at the business models and business cases for the overall exchange of data, as well as how to engage consumers more as participants in the exchange, and being able to understand the benefits of this kind of network-based exchange. There other aspects in this kind of key points column about measuring the speed of network adoption and being able to understand how many lives are covered, how to know how well the kind of scope, scale, amount of use cases are being supported through the networks. And so that was kind of one of those aspects around better understanding the health IT infrastructure and its maturity that some of the stakeholders are acknowledging we could do a better job at. And equally, where we do have a lot of data sources now, and we have some structured ways in which to exchange data like CCDAs, there are many other data that can be exchanged, and in some cases, the health IT systems, EHRs, et cetera, that may receive that data may not have a place to put it in a way that's really accessible to the users. So in terms of action items, there were a number of different components here that came out. I think the health information exchange networks have a kind of clear understanding that the future is going to include more API-oriented exchange, likely via the FHIR standard, as well as ways in which they may be able to leverage their network at scale to facilitate greater consumer access, and clearly again to help provide better business cases for the particular way in which we can exchange data as it's available today. And I believe this is the last one that I've got here. And the one other area that I would be remiss if we didn't mention would be research and standards that could be used to advance research. So we had presentations from work going on related to the All of Us research program from Vanderbilt, from Mayo Clinic, specifically on how to do some standardization work that's called Sync for Genes. And then there's a broader group discussion about the kind of intersection between clinical standards and research needs and research data, and the kind of different scope and scale. And so one of the particular observations that came out was that at least the consensus in the room or the kind of perception in the room was that they really didn't feel like they needed a whole lot of new standards to be created in order to enable and support research, but instead that the standards needed to be really used and adopted, and can converge between clinical and research environments. And whereas clinical care requires a certain level of data accuracy to, keep everything flowing, research usually has a different aspect, or looks at the data through a different lens, which includes further data granularity. So there's kind of that difference in the scope and detail from the different stakeholder perspectives. But largely, there's a genuine interest in the research community and the clinical community really partnering together to use the mindshare and existing standards that exist today. So basically preparing myself for any questions that you may have. The one thing that I did want to do would be to say thank you again for your time. Thank you again for attending, if you did, either virtually or in person. And the one thing that I would note would be that if you love to be involved in ONC things and you want another opportunity to engage, we are planning and going to hold our annual meeting, which will be November 29th and 30th this year. So be on the lookout for more information about that.
Thank you very much, Steve. And if anybody has any questions, go ahead and type them into your GoToMeeting or GoToWebinar control panel and hit enter, and we'll get those questions started. I think the first question I have for you, Steve, is how can WEDI better support ONC?
So it's a good question in terms of there's a lot that WEDI does for the kind of health IT community, and so there are a few areas that I would say are right in my wheelhouse. So one is your continued engagement and support to provide information that may be relevant to what's called the Interoperability Standards Advisory. I didn't go through my normal kind of here's all the things I do stock presentation in service particular kind of summary request for today. But that being said, I believe our formal comment request period is open for the Interoperability Standards Advisory, and I know that many of you have engaged with it before, so continuing to do that. The other area would be, as I'm sure you all well are aware and participating, there's we have seen an evolution and really a convergence from the administrative side and the clinical side, and I think as that continues, WEDI's expertise in, you all collectively in helping to shape, what that looks like, and helping us policymakers better understand, the trajectory of the industry and where certain needs are, or, particular practices insofar as, they may result in information blocking or other types of things as new policy gets created. Keeping that open channel of communication is really important, and also being, providing us feedback at any point in time that it's relevant is really always valuable to us.
Thanks. We've got some more questions rolling in. Can you tell us a little about the ONC RFI that was released?
Sure. So, and I'm sorry that there's a competing call with this right now, right? And so one of the requirements of the Cures Act included what is called an EHR reporting program. And this is not like the Meaningful Use Program or the EHR incentive program type of thing. This was largely to address stakeholder interest, congressional interest in having more transparency around certified health IT. And it's actually quite interesting from a kind of legislative policy perspective. Often when you look at statute, there are kind of the broad strokes and framing of congressional, legislative intent policy that gets anchored into a law. This portion had quite a bit of text and kind of prescriptiveness in terms of Congress's interest in us fulfilling this from the executive branch perspective. So the RFI seeks to be the first step toward implementing this section of the Cures Act. and we under this provision for the EHR reporting program, Congress laid out a number of areas in which they thought that reporting criteria could be developed associated with health IT, a certified health IT. And so we really kind of stick to that aspect of the statute and march through each of those categories, including some additional ones that were, let's say, MAYs, in quote, MAY, provisions that we included in the request for information about what do people think the kind of reporting criteria that could be developed for these areas. And the other important kind of component that you can keep in mind, so I can do my best from a statute education perspective. As I noted in passing in one of the panel summaries, track summaries for the Interoperability Forum, there are new provisions in the Cures Act that requires ONC to adopt what are called conditions of certification. And those conditions of certification will apply to health IT developers at a kind of organization level as opposed to the product itself. One of those conditions of certification is that the health IT developer participates and reports on the EHR reporting program criteria, whatever those are. And so they will have a compulsory, as I like to say, responsibility as the statute so dictates to report on whatever those criteria are ultimately when they're developed. So there's kind of an important aspect of working with industry to get a better sense of what would be those binding requirements that, or things that health IT developers on which they would need to report. Then the flip side is the way that the statute is constructed, there would be a mechanism and a way for healthcare providers to report on their certified products as well. And so, we've had numerous analogies of, is this Yelp? Is this Amazon, type ratings? Are there particular, specific types of things within that? All of those are really kind of tactical and strategic aspects that we lay out, in the kind of request for information, but really we're at the criteria development stage, because as we look to implement the statute, there are a number of as you chunk it up, a number of phases that we need to go in a serial fashion. And the first step is getting reporting criteria for this EHR reporting program. So our hope is through this RFI, and we are in the process of hiring a contractor to help facilitate a coordinated approach in public-private engagement to get more feedback on what reporting criteria should be. Ultimately, we would wind up with a first set of reporting criteria that could then follow the statute and the subsequent steps. Sorry, that was a little bit of a long-winded answer.
Thanks, Steve. More questions. Oh, goodness. Sorry, they're piling up. Is patient matching pushing the initiative for a national patient identifier? What is the status on that identifier?
All right. So we get to go to one of my favorite topics as well. It's just I've been coining the phrase health IT history here. So as those of you who may know, and this will go back all the way to 1999, or even 96. So when HIPAA, the statute, was passed, it had a whole set of identifiers that, from an administrative simplification perspective, needed to be adopted, promulgated through rules. So I'm sure you're all familiar with, NPI and, other kind of identifiers that CMS has put out for, different stakeholders in the healthcare spectrum. One of the identifiers in the law was to create a unique patient identifier. And then in 1999, as part of the appropriations law, Congress prohibited HHS from using any funding toward the establishment and promulgation of rules to establish a unique identifier. So from any action from an HHS perspective is still limited by that law. So to the degree that we do look at patient matching, it really kind of ranges from research and the kind of challenge oriented work that we did, partnering with other agencies, and other stakeholders in the industry, and looking at ways in which we can help improve the overall ecosystem. So that would be through the example I mentioned earlier about the patient demographic data quality framework, in terms of how to, make sure that the data that people are using for patient matching are higher quality, more standardized, et cetera. So the other component is generally just keeping our own awareness of, what's going on in the field, how different stakeholder groups are approaching both matching and the creation, for lack of a better word, of their own identifier for their own ecosystem. In some cases, that scales quite a bit. If you're talking about a large or a state-based health information exchange, but that's the current state. We're supportive of a lot of the innovative work that many different companies are doing and stakeholders to improve matching, and we're there, cheering them on, as well as learning.
Great. And here's the last question. Can you elaborate on the forthcoming fall regulatory rules you mentioned early in the call?
Sure. So the kind of high-level sketch around the regulatory aspect is we are in the proposed rule development stage, so you haven't missed anything yet. The Cures Act includes a number of components, as many statutes do, that require additional regulatory interpretation and kind of going through that notice and comment process. So the kind of predominant elements that you can expect from the rulemaking as the statute so dictates is a whole new body of work on what are called the conditions of certification. And so there are a number of those, and I'll just kind of recap that really briefly. The conditions of certification, just to emphasize this again, are kind of a really important kind of pivot and evolution for the certification program, whereas certification as it stands today focuses on the product or software, right? And we have certification criteria and they meet technical standards and functions. The conditions of certification are more business practice and behavioral and apply to a health IT developer as a whole. So there are 7, if I got my number correct today, conditions of certification. One is around the developer's business practices associated with information blocking. So there's a tie-in from a certification perspective and information blocking to the primary information blocking section in the statute that we're also going to be regulating, but I'll get to that in a second. There are other conditions of certification around restricting their customers' communications. So this gets to, complaints about, being able to share information for safety or other types of issues associated with the product, or, other types of aspects where Congress had heard from industry that their voices were being kind of mooted in terms of what they, what those customers wanted to say in public settings about their product. There's another condition of certification around providing reasonable assurances to the secretary associated with the product ability, the vendors' practices, or the health IT developers' practices associated with the exchange, access, and use of what's called electronic health information. And so it's kind of 2 new phrases that I'll leave with you as well. The statute uses this exchange, access, and use as a kind of set of verbs consistently across many of the statutory sections. And they also refer to electronic health information as well. So for those of you that are familiar with, PHI and EPHI and IIHI, you've got EHI now as, yet another acronym of kind of electronic health information, terminology. There is another condition of certification that requires health IT developers to publish and make available application programming interfaces that can be used, quote unquote, without special effort. And so we have to go through the regulatory processes to describe what that means and what constitutes, an API that can, that cannot be used without special effort. All those dynamics that are in play there. There are a few others that are just attestations. There's one that's an attestation in particular. There's the real world testing one that I covered earlier. And then there's the one on participating in the EHR reporting program. So that's a whole body of work that has nothing to do with new certification criteria or anything like that. and that's all de novo kind of policy that's coming out of the 21st Century Cures Act. There are obviously elements of implementing those provisions that will affect the current regulatory infrastructure. So I think, it's reasonable to expect that we will have to tinker with certain ways in which the program is administered and how health IT developers are, kind of the oversight, posture and policies that we have. And then the other component of the rule includes how we're going to handle what are called the exceptions to the information blocking definition. And the kind of one other public service announcement there is the way that the statute is structured is that it defines information blocking. ONC is taking on the regulatory responsibilities for establishing those exceptions, but when it comes to enforcement, predominantly the HHS Office of the Inspector General is given the ability to levy penalties for on top or onto what are health IT developers, health information exchanges, and health information networks. So that's kind of their scope from an OIG perspective, and the fines can be up to $1 million per violation. So again, this is kind of going to be a new de novo area both for policy and legal practice, and I can't emphasize that enough. So for those of you that have experienced other areas like Stark and anti-kickback or something like, something along those lines, where these are kind of really deep areas where you have real law firms that kind of take on and specialize in this. You could foresee some of that specialization occurring both in the kind of legal and policy advocacy practice as well. So as we look at implementing the statute, we're going to be looking at creating the exceptions. As you now know, there's a tie-in to information blocking with the condition of certification that kind of references the same thing. So that means that health IT developers, if they're ultimately found for information blocking, there could be ramifications to their certificates for their product. And then there's the corresponding kind of fines associated with the OIG's enforcement that apply to, again, health IT developers, health information exchanges, and health information networks. Healthcare providers are also referenced in the information blocking statute, and I would be remiss if I didn't mention that. The financial penalties do not explicitly apply to them. However, there's authority and kind of a charge from Congress to the Secretary that the Secretary shall look for appropriate disincentives through the various levers that are available to prevent any information blocking behaviors that may occur from a provider perspective. So when we look at the exceptions, we're approaching the exceptions inclusive of that entire universe of participants in information blocking. So that's a kind of rough overview of what the statute says and what you can expect the rule to address.
Thank you very much, Steve. We certainly appreciate your time and participating in this webinar, and of course, we definitely appreciate your enthusiasm for health IT, and WEDI looks forward to continuing to work with ONC and help advance the industry. So thank you also to our fantastic participants and all your great questions. We certainly appreciate it, and we look forward to next month's WEDI webinar series for just our members. And please make sure you register for our national conference coming up in October as well. If you have any questions about that, feel free to email me, and I will help take care of your registration and get you set. So thank you again, everybody, and I hope you enjoy the rest of your week.